My name is Laura Vanderhill, and I'm a Quality Improvement Specialist with HealthCentric Advisors, which is a member of the iPro QIN-QIO, and I'll be your host this afternoon. Before I introduce our speakers, I do just want to cover a few things. Next slide, please. So our topic for today is adverse drug events. Next slide, please. So as I'm sure everybody knows by now, for Zoom, you can access the chat button at the bottom of your screen in the black icon bar. We do encourage you to use chat today to ask questions and introduce yourself throughout the session. Thank you. Next slide, please. So today's session is being recorded. The slides are available on the website along with the recording after today's session. We do want active participation. We ask that you keep yourself on mute during the presentation. If you haven't already done so, please introduce yourself in the chat. Thank you. Next slide, please. As many of you know, the iPro QIN-QIO covers 11 states and DC, and our website and contact information will be shared in the chat. Next slide, please. So our small talk series is being held through June of this year. It's designed to have 20 minutes of content followed by 10 minutes of discussion and questions. And our framework is to share a challenge and identify some successful interventions to bring about a good outcome or result. Next slide, please. So without further ado, I do want to introduce our speakers for today, Anne and Charlotte. Anne is the Senior Director of Drug Safety and Chronic Disease Management and the Program Director for Ohio for the iPro QIN-QIO. Anne is a pharmacist. Charlotte is a registered nurse and the project manager for Clarence in Maryland, who's also a member of the iPro QIN-QIO. Thank you both for sharing your expertise with us today. And with that, I'm going to hand it over to Charlotte.
Well, great. Thank you so much, Laura. And welcome to today's session on adverse drug events. We're very excited you are here to join us. So we could ask ourselves, why are we even interested in talking about adverse drug events in nursing homes or in general? Why this interest? Well, the challenge is as follows. Nursing home residents are vulnerable to experiencing adverse drug events, ADEs for short, and they result in increased emergency department visits, hospitalizations, and readmissions. So in order to address this challenge, we have to look at what can be done to prevent this from happening, or at least try to identify some factors contributing to this. So in other words, we're going to look at some interventions. And then finally, the goal is to arrive at a measurable decrease in adverse drug events, because as I mentioned, we know they result in ED visits, hospitalizations, and readmissions. Next slide, please. So as I mentioned, residents in nursing homes, they are already a vulnerable population and experiencing adverse drug events at a higher rate. We know that the highest ADE rates in this elderly population are due to 3 high-risk classes: anticoagulants, opioids, and diabetic agents. And we also know that adverse drug events, they have increased during the COVID-19 pandemic, and often they occur during the care transitions. And we will talk more about this later in the presentation. So I think for now, I'll turn it to Anne to talk about some interventions and medication discrepancies. Anne?
Thank you, Charlotte. So quickly, I wanted to go over some definitions. An adverse drug event is when someone is harmed by a medication. Different organizations have different definitions, but that's basically what an ADE is. And we'll be saying ADEs throughout the rest of the presentation. And then some quick facts. I think the takeaway that I want you to think about is that half of ADEs are preventable. So we'll be sharing tools and resources to help you prevent those ADEs that you can. Next slide, please. Medication discrepancies occur usually, the most frequent time that they occur is during care transitions. That's another piece that we're going to focus on during this presentation, where hospitals and nursing homes, or hospitals and home healthcare agencies, or any transition of care might be able to reduce those preventable ADEs and prevent medication discrepancies through a thorough med-rec, medication reconciliation. So medication discrepancies might be unintended or unexplained or undocumented differences among medication lists across different sites of care. So some examples are omissions, duplications, dose frequency or route of administration errors, or the drug name is discrepant or incorrect. Some discrepancies are differentiated as intended or unintended. Intended discrepancies would have some kind of rationale documented for why that discrepancy has occurred. We know that it's really difficult to find that rationale. So part of the work we do is try to help get that rationale documented also. And then medication discrepancies are identified and resolved through a comprehensive medication reconciliation program. Next slide, please. Quickly, I'll go through a few slides. We have some data from Medicare Part D claims and Medicare Part A claims for nursing home residents across our QIN-QIO region. And we identified ADE rates to the top, those top 3 drugs that we're concerned with: anticoagulants, anti-diabetes agents, opioids, and antipsychotics. And we added antipsychotics in because of the nursing home setting. And we identified that anticoagulants led opioids as the highest rate of ADEs in nursing homes in our QIN region, followed by antipsychotics and then anti-diabetic agents. So I just wanted to point that out. You know, I know we're all very focused on opioids, but it's really the ADEs that we see. The ADEs defined as a hospitalization due to a bleeding or thrombotic or clot event for anybody who's on an anticoagulant. And you can see that that's higher than the opioids. So we want to focus, think about what you're doing in your facilities with anticoagulants and how to prevent that. And we'll be talking a little bit about that. The following slides, if you could go to the next slide, please. I won't belabor them. They're a breakdown of anticoag, keep going, opioids, and diabetes agents by state for nursing home settings. So when you get to see your slides and you download them, that's when you can take a look at your particular state and see where you're falling out in those areas. Next slide, please. And then antipsychotics, of course. Next slide. So we want to focus here on care transitions. A few years ago, the Department of Health and Human Services published the National Action Plan for Adverse Drug Event Prevention. And you can see that we provided you the link at the bottom, I believe, of the slide, and it's also in chat. And this guide identified several root causes for ADEs that are preventable for these 3 high-risk drugs, and that's communication failures, suboptimal management systems, and inadequate access to medication lists and lab results. And they came to the conclusion that medication reconciliation as a care transition strategy is important to reduce potential medication discrepancies. So that's very, very important. And as you'll see, when we have a resource, we are listing them as part of from our QI library at the bottom of each of the slides, so you know how to access the resource. Next slide, please. And then I'm going to hand it over to Charlotte. Thank you.
Thank you so much. Thanks, Anne. Yeah, so let's take a look at some interventions for nursing homes. What can nursing homes really do about this now that we have all this good information and all this data? Well, for starters, identifying medication discrepancies during the care transition is key. We don't want to just identify the issues or medication discrepancies. We also want to address them, act on them, and maybe even do a root cause analysis. So when you look at a new resident's medication list, you should be proactive, look for risks for potential ADEs, and you should care plan these issues or these potential ADEs for early identification and resolution. So care planning is a very important part of this puzzle as well. Now we have some tools and some resources that we will introduce in the next upcoming slides, and they can be very helpful to you. And another intervention you might want to benefit from, or you might benefit from, and you might consider, is establishing a quality improvement plan for eliminating and modifying root causes of discrepancies of ADEs. And this is where your QABI program and QABI team can come into play. But we'll talk more about this later. So next slide, please. So this slide is really just a slide to show you some examples of the high-risk medications in different drug categories and drugs associated with what we call preventable adverse drug events. And I think the key word on this slide is preventable. As Anne mentioned earlier, over 50% of ADEs, they are actually preventable. So that's a fairly large number. So on this slide, you'll see the drug category and the name of the drug on the left-hand side. And then on the right side, you will see a list of all the preventable ADEs, adverse drug events. So it's just a quick overview of some common high-risk medications. Yeah. And I think, Anne, did you have a couple of examples you wanted to mention?
I did. I wanted to highlight with opioids, some of the things that we learned in our care transition coalitions were that the date and time of the previous dose and when the next dose is due is critical. And with opioids, we're talking about preventable ADEs. We've seen opioids that were given too soon after the most recent dose from the hospital. It was given too soon in the nursing home, and we've had adverse events happen due to overdose. And then we've also seen when opioids, when it was not clear, when opioids are not given during the transition time, so that the resulting in a resident being transitioned, or a patient going home or going to home health care is transferred while in pain. We want to make sure from the hospital side that the medications for pain are administered at a time within an hour of that discharge, so that it's working and peaking during the potentially painful time when they're transitioning from an ambulance or a car, et cetera, where they're being manipulated and could have extra pain. So we want to think about that too. And then the other thing is lab results. So warfarin is a drug that we see a lot of problems with, and I know we're transitioning to the newer agents in many facilities and in society. But having that INR done within 3 to 7 days of transfer from a hospital to home or to a nursing home is critical. We've seen lots of problems with overdoses and underdoses by not monitoring warfarin soon enough after transfer. And again, 3 to 7 days. And then insulin. So we've seen lots of problems with blood glucose evaluations not being done right prior to transfer, so you know what the status was prior to resident transfer, and then not being done in a critical time post-transfer. And we've seen adverse events due to hypoglycemia where people were given insulin or given their oral medication that can cause hypoglycemia without having a good solid assessment upon admission to the next receiving facility of what their blood glucose was. So I just wanted to take some time to talk about some of those cases that we've seen. Thank you, Charlotte.
Yeah, thank you, Anne. No, these are great tips and very important to remember as a receiving staff member in a nursing facility. So thank you for highlighting some of these drug categories. We can go to the next slide, please. So how can we use this information on drug and adverse drug events, and how can we care plan for preventable adverse drug events? Well, on this slide, and I know it's very busy, so I don't expect everybody to be able to read this, but this is a tool that was developed by CMS, and it's called the Nursing Home ADE Trigger Tool. And some of you might be familiar with it already. So what this tool was developed for, it was really intended to assist surveyors identify potential risk factors, signs and symptoms, and interventions that can take place for different types of drugs. But you can certainly use this for the same reason in your facility. This example is for change in mental status related to opioid use. Basically what you're looking at here is on the right side, the column on the right side really has a list of probing questions that can assist you in further investigating ADEs, preventable ADEs. And this trigger tool can also be used as a training material when you're educating your staff, whether it's new staff, onboarding new staff, or existing staff, and you want to do a little refresher course. So at the bottom of the slide, you will see a link to where you can find the full trigger tool, because I think it's like 14 pages long, but you can find it in our resource library. So, all right, we can go to the next slide, please. So on this slide, we're just listing potential symptoms of drug therapy problems, and I'll just highlight a few, and I'm sure you're familiar with these. New or increased confusion, and new or increased depression, delirium, and new onset of incontinence. That can be a little tricky sometimes to identify. Weakness, loss of appetite, falls, changes in speech, blurred speech, or some of these potential symptoms. So I think the key thing to notice on this slide is knowing your residents' baseline characteristics. It's very important, and to be alert to whenever there's a worsening or a change in a condition. And then something that I think sometimes we don't forget it, but we may not pay as much attention to it as we should be. But listening to the residents or the care partners' information about changes in the resident status. That is absolutely key to this sometimes. And of course, take the information very seriously. Don't disregard and blow it off. Take it seriously. There's a reason they're telling you what's going on. And then create a care plan where you actually can monitor medications that are related to these these red flags. So these are just some of the things to be aware of. So we can go to the next slide, please. So again, what interventions are we looking at here for you to implement in your facility? Well, for starters, we know that decreasing adverse drug events really begins with very good admission medication communication and medication reconciliation, because this can identify and solve discrepancies and drug therapy problems. And I'll show you a tool on the next slide. I think maybe Anne, you were going to address this and speak a little bit to this. And you're on mute.
Yes, I was on mute.
Thank you.
So
Thanks, Anne.
the classic, I was on mute. So so this is just quickly, you can look at the slides and go to the resource and peruse this on your own. But a couple of areas, you've probably seen warm handoff guides. This one's a little bit different because we added a section on how to identify any cautions that you want to convey to the receiving nurse. And duration of therapy might be missing in some drugs, classically for anticoagulants. Sometimes we miss the duration of therapy post orthopedic procedures. There might be a duration of therapy of 35 days and that gets missed. Antibiotics are a little easier. We're used to seeing the stop date for that. So keep an eye out for those things. And then we provided you an example of what a good warm handoff might look like for these kind of drugs. Next slide, please. The next tool is really very helpful when you're trying to identify root cause for care transitions, medication discrepancies on your receiving medication reconciliation. Identify those discrepancies. It's a tool that helps you identify them and communicate them back to the sending facility to resolve any issues. And I'll let you look at this tool too. Go and grab it. Meet up with if you're a nursing home or a home health care agency, go and speak with your hospitals and see if you can get together in your discharging hospitals and collect some data around this. We identified that 64% in other communities, 64% of the medication discrepancies were high risk. And this is a tool that helps you identify root cause and fix that. Here's an example. We saw Coumadin orders, warfarin orders that were alternating doses, like I think it was 3 and 7 milligrams. And the EHR was only picking up on the 3 milligram order of every other day. And it was dropping off the 7 milligram order of every other day. And it was just a simple click of the button to fix that error. But in the meantime, patient harm occurred because of that electronic health record error. So those are the kind of things that you want to think about when you're discussing care transitions issues with your in your communities. Next slide, please. And we also have essential communication elements for transitions of care for the anticoagulants, pain management, and diabetes management communication elements. And these are things that should always be communicated across care settings beyond the nursing warm-to-warm handoff. So it should go in the discharge summary. And so we're looking for facilities to really think about integrating these elements into their EHR to make it a nice, concise, brief transfer summary. And we've published on all of them now. The next publication we published on anticoag, pain management, and we have I think these are hot links to those articles. And the diabetes got accepted in diabetes therapy, and we can share that link when it's done. It'll be in our resource library. Next slide, please. And I'm going to pass it off to Charlotte for some more communication tools.
Yes, thank you so much, Anne. Yeah, I wanted to, on this slide, there's a number of examples of communications tools that you can use both within your nursing home and in the care transition, maybe between nursing home and hospitals or other care settings. And all of these tools, you can find them in our resource library. On this particular slide, we actually just highlighted one of the tools called Stop and Watch, early warning tool. And it's a very good example of how you can use this for a communication tool within your nursing facility. Some of them, I wanted to highlight that as well. Some of them are actually translated into other languages as well. So that could be useful to you. And then on the next slide, just another example of a communication tool, and I'm sure a lot of you are familiar with this, but I do want to highlight it. It's very useful. It's the SBAR Communication, because it really does address and describe the situation that you're currently in with the patient or resident, the background and the context of specific data, the assessment of the actual problem or issue, and then any recommendations of what actions might be that you might take. So SBAR Communication, a very valuable tool as well for communicating issues. And on the next slide, I do wanted to also highlight something else, that within a nursing facility, another thing to keep in mind is to look for Section N in your MDS, because this addresses the medication regimen review. You should always audit for accuracy to make sure you identify issues or maybe preventable ADEs, and this should be part of your care plan as well. You can look at quality measures through your CASPER reports, and I just listed 4 different scenarios here, 4 different measures that you can take a look at, and they could be helpful in identifying some issues within your facility as well. And then, as I mentioned before, you might consider reaching out to your quality team so that they can potentially start a performance improvement project. On the next slide, just wanted to say that if you do decide to include your quality team, here are some steps to consider. Identifying ADEs, as we mentioned, it starts with admission orders, identifying and resolving any medication discrepancies. And then you can use the medication discrepancy data collection tool that Anne mentioned, because this tool is really structured to help nursing homes and other post-acute care settings to collect data and categorize the data in different types of medication discrepancies. And once you have identified and looked at the data, you can discuss it with maybe the discharging hospital, and together with them, identify specific processes that could be an opportunity for improvement and help prevent ADEs in the care transition. So you can start by focusing, the data collection on residents with that were admitted on high-risk medications, the 3 medications that we mentioned in the beginning of the presentation, and then try to set up processes using some of the communication tools that we have presented to you today. And I think with that, I will turn it back to Anne, and you can take us home.
Sure.
Anne?
So we can skip the next 2 slides, but and let you look at them later. But one of those slides is the new do not crush list. So you'll want to definitely grab that and know that. And we'll hand it off to Laura now. Thank you. Thank you, Charlotte.
Thank you, Anne and Charlotte, for that great presentation. So we do want to make sure we have time for questions. So while you're thinking of a question, you can take yourself off mute or please, put it in chat. But I do just want to take a quick moment to remind everybody about the benefits of boosters, and you can find more information on the CDC website. Next slide, please. Oh, and the next slide, thank you. So as I said, feel free to chat in. We want to make sure that we do get to any of your questions. And Charlotte and Anne, as you could see, their contact information is in the slides if you have questions later.
Yeah, thank you so much, Laura. Yeah, please reach out if you have any more questions. We'll be happy to assist you.
Thank you. So I would love to hear from people in chat, or unmute yourselves about have you seen any anticoagulant ADEs in your facilities? Any opioid AD, any ADEs with these particular drugs? I've had unfortunately lots of opportunity. I was a consultant pharmacist for 16 years, and I've seen the gamut of ADEs that have occurred in ways that we can prevent them, and I covered some of them in the slides and some of our cases. One thing I did want to kind of bring up was during this time of COVID, we've seen lots of staff turnover in nursing homes, and the importance of upfront training and safe medication practices when you get new staff or if you have travel staff. So understanding, especially if you're using any liquid opioid dosage forms where the dosing may differ, it might be 10 milligrams per mil versus Roxanol, which is 20 milligrams per mil. We've seen, unfortunately, lots of errors around that, especially with new staff. So I just wanted to put that out there for people to think about. Charlotte, can you think of anything else that we want? Any other tips? We have another minute. I don't think we have any questions in there. Or Kathy, do you have
Charlotte?
questions?
Yep, Charlotte, just one thing. I don't see questions in chat, but especially now, can be a challenge. So what's the first thing you think providers could do to get a good ADE prevention plan in place?
That's a great question, and I think that one of the things that they can do is identify maybe an ADE champion per se, if you want to call it that, somebody who actually takes the lead on making sure that people are aware that they need to look for, do the medication reconciliation on admission, and really make sure that you go through the documentation and have focus on that. So maybe identifying maybe one or two people that really want to take the lead and make sure that this is happening in your facility. That would probably be one of the first tips I would give a nursing facility.
Thank you, Charlotte. That's a great segue to our next slide. So as you were just saying, important to have a champion and start small with your steps of change. And as we said before, please feel free to reach out to us with questions or needs. Next slide, please. So here's our website. It's a great way to connect with our resource library, as we were talking about earlier, and to connect with us with your questions. Next slide, please. So your feedback is really important to us. We will be sending out a brief evaluation form, and really appreciate it if you could fill that out for us. Thanks. Next slide, please. And so we do have upcoming sessions. We hope you can join us. Information is on our website, and we also have some office hours coming up in February. Next slide, please. Finally, and most importantly, thank you for all that you do. I hope you have a good afternoon, everyone. Take care. Bye.